Commemoration. Today, our theme is Now is Time for Hope and Healing from Health Disparities. So that is our theme today. And our Dr. King quote for today is, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." And I will share personally that that's one of my favorite quotes of his. So we're going to talk today about people of color and COVID-19, addressing health disparities and vaccine equity. And we're really excited to be able to talk about this across all of our diverse communities that we serve. So the COVID-19 pandemic, caused by the novel severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2, has disproportionately impacted Black and African Americans, Hispanic and Latinx, Native American, and other minoritized communities. These communities continue to be impacted by high rates of infection they're 2 to 3 times more likely to die from COVID-19 than white Americans. Last month, 2 vaccines, Pfizer and Moderna, were approved for emergency use authorization by the Food and Drug Administration, and Johns Hopkins Medicine began vaccinating its frontline employees on December 16, 2020. While the vaccine offers hope for an eventual end to a devastating pandemic, many minoritized and marginalized communities are reluctant to take the vaccine because of past experiences in which medicine and science have violated their trust. This symposium will be a moderated panel discussion with our Johns Hopkins Medicine experts to discuss how we can address these concerns and ensure equity and vaccine education as well as distribution. And there will be time for Q&A at the end. We ask that throughout the symposium, if you could enter your questions into the Q&A box, and there'll be time to answer those at the end. Our objectives are to increase your knowledge in the following areas. We want to what are the contributors to COVID-19 disparities in Black and African American, Hispanic and Latinx and Native American communities? What is the definition of an emergency use authorization, or an EUA, that you've heard a lot about? What were the characteristics of the Pfizer and Moderna COVID-19 vaccine trial participants? So for example, the distribution of race, ethnicity, age, chronic health conditions. What were the components of Operation Warp Speed, and what was its role in vaccine development, and what did that mean, and why was it necessary? And then finally, the importance of ongoing public health COVID-19 prevention strategies, both personal and community-based. So I'm Sharita Golden, Vice President and Chief Diversity Officer for Johns Hopkins Medicine, also a professor in the School of Medicine. And it's my great pleasure to introduce Dr. Risha Irvin, who's the co-moderator. She is an Assistant Professor of Medicine in the Division of Infectious Diseases at the Johns Hopkins University School of Medicine, and has been leading a really engaging medical religious partnership around COVID-19 education, and has really co-partnered with me on a lot of our community vaccine engagement efforts. So thank you, Dr. Irvin, for agreeing to moderate the panel today.
Thank you so much, Dr. Golden. Really excited to be here today and talk with you all about COVID-19 and engage all of our wonderful panelists today. So first, I'd like to introduce Dr. Damani Piggott. He's an assistant professor of medicine in the Division of Infectious Diseases at the Johns Hopkins University School of Medicine and the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health. Dr. Piggott has been studying COVID-19 in the African American community, so we really want to engage him on this topic today. So Dr. Piggott, what factors have contributed to the disparities in COVID-19 infections, hospitalizations, and mortality in Black and African American community?
Thanks, Dr. Irvin, and thanks everyone for having me join today. I think we definitely continue to be at a really sober point for this pandemic. Over 90 million infections as of today, and more than 1.9 million deaths as well as of today. And here in the US, there's been over 22 million people infected with this virus, and more than 380,000 people have died as a result of this infection. And we know that the number of COVID-19 cases have been surging over the last several months. And in the last few days, we've seen over 4,000 people die from COVID-19 each day here in the US. The highest number of daily deaths from COVID-19 since the pandemic began, and the equivalent of more than 8 plane loads full of people crashing into the ground every day. And so as we consider these numbers, the human toll across all communities, has been truly staggering, causing immeasurable grief and disruption to so many lives. As Dr. Golden shared, particularly devastating has been the disproportionate impact of this virus on those who have been historically the most vulnerable to poor health outcomes in our society. And in this regard, over the course of the pandemic, it's been really evident that COVID-19 has had a particularly ravaging impact on the Black community and other communities of color. Rates of COVID-19 cases in the Black community have been reported to be about 1.5 times higher than that seen in the white non-Hispanic population. And not only is more COVID-19 disease being seen in the Black community also has been experiencing more severe COVID-19 disease and more COVID-19 related death, with African Americans reported to be about 4 times more likely to end up in the hospital due to COVID-19 and 3 times more likely to die. And I think several factors, Dr. Irvin, have been proposed as contributors to the severe disparate impact of COVID-19 in the African American community. First, African Americans have been more likely to work in jobs on the front line of this pandemic, jobs that have been essential to the continued functioning of our society. These include jobs providing essential services, whether it be in the food industry, transportation, security, and other sectors that have required continued in-person work since the beginning of the pandemic. And such work has really been crucial to keeping us all going and allowing us to survive during this pandemic, but appreciably being in these positions brings a potentially higher risk of COVID-19 exposure and infection. African Americans also have had higher rates of underlying health conditions such as diabetes, high blood pressure, stroke, chronic kidney disease, and others that have been associated with more severe COVID-19 disease, including greater hospitalization and death. Additionally, longstanding multi-generational disparities in living conditions, income, wealth, and access to health systems and health services may also further undergird the disproportionately worse impact of COVID-19 on the Black community. For example, African Americans may be more likely to have living conditions rooted in historical residential segregation that limit their ability to engage in primary COVID-19 prevention measures such as physical or social distancing. The prison population is another population group that has seen substantively high COVID-19 attack rates. And Blacks, who make up just about 13% of the US population, actually make up 33% of the US prison population, a disproportionate rate also with deep historical antecedents that rarely requires prospective attention. But in the context of COVID-19, this connects the greater likelihood of COVID-19 exposure within or through indirect contact for the African American community. Homeless shelters are another portal associated with a substantively increased risk of COVID-19 exposure and acquisition. And again, while African Americans make up just about 13% of the US population, African Americans make up 40% of all homeless persons and 47% of those in shelters. African Americans also long have had less financial resources, with adverse implications for effective access to healthcare. This historical circumscription in financial resources has included lower income, substantially less wealth, the highest rates of unemployment, and notably lower rates of healthcare insurance. And we know, as Dr. Golden mentioned, further historical challenges have existed around institutional trust for the Black community, precipitated in part by notable adverse prior engagements with health systems that actually may impact how public health messages, even today, may be received in the Black community, including around vaccines. So all these factors have substantive implications for access to treatment and care, specifically in the context of COVID-19, and more broadly, have substantively challenged, I think, our critical goal of ensuring that the opportunity to attain full health potential is actually afforded to all. So I think as we really, in closing, as we continue to face this really heart-wrenching pandemic and the marked devastation it continues to bring to our human existence, there's actually a quote from Dr. Martin Luther King Jr., for me, whom we are commemorating this week, that I've reflected on through much of this pandemic, which states, "We are all caught in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one directly affects all indirectly. This virus has shown us clearly that we are indeed inextricably intertwined and all in this together." With the tremendous devastation I think that COVID-19 continues to bring, Dr. Irvin, there's a fierce urgency of now, and we have to lift all boats in common purpose if we're going to rise above this pandemic together, using every tool at our disposal, leaving no one behind. Safe and effective vaccines hold promise as one vital tool in our armamentarium in the fight against COVID-19, For many other infections, safe and effective vaccines have historically saved millions of lives each year. And we know that vaccines have been a vital tool in providing us protection from life-threatening infections and keeping us well from our youngest years. I think being able to harness the power of safe and effective vaccines against COVID-19 has the potential to really shift the horrible course of this pandemic and put the immeasurable suffering and grief it has brought behind us. And again, though, as we consider application of safe and effective tools in our fight against COVID, it again remains critical that no one is left behind, particularly those who have been most severely impacted by this pandemic, namely those who we have seen are most likely to get infected, be hospitalized, and die from this virus at astronomical rates. So just in closing, hopefully as we apply Dr. King's precepts to get past COVID-19, we also can apply Dr. King's precepts in continuing our quest to achieve equity in health more broadly. And hopefully this pandemic has shown us that doing so will actually be to the benefit of all of us. Thanks, Dr. Irvin.
Thank you so much, Dr. Pickett. I think, many of us have studied health disparities and known that they existed for years, but COVID-19, as you say, has really highlighted those issues for us again. So now I'm happy to move on and introduce Dr. Kathleen Page. Many of you may know her. She's an associate professor of medicine in the Division of Infectious Diseases at the Johns Hopkins University School of Medicine and is co-director of Centro Sol. Dr. Page has been really working in Latinx and Hispanic communities for many years in Baltimore and in Maryland more broadly, and was really the driving force behind getting COVID-19 testing rolled out in the Latinx and Hispanic communities in Baltimore. So very pleased to have her now come and present to us. So Dr. Page, in addition to the issues that Dr. Pickett just discussed, what additional challenges have contributed to COVID disparities in the Latinx and Hispanic community?
Hi, Risha. Thank you for that question. And thank you to you and Sharita for inviting me to be part of this panel. And so, I think a lot of the issues that Dr. Pickett mentioned impact many communities of color, African Americans, but also Latinos. And I think as one of my patients said to me early on in the pandemic, and I think he said it very well, he said, this may be the same storm for everyone, but we're not all in the same boat. And surviving that storm really depends on what boat you're in. And unfortunately, not everyone is in a beautiful, sturdy boat. I would say that what we have seen, not only in Baltimore and in Maryland, but also throughout the country, is that among Latinos, of course, Latinos as other groups are very heterogeneous, and many have been affected, but in particular, those that have been affected most profoundly have been low-income Latinos, and in particular, immigrant Latinos or those who live in immigrant families. And certainly we saw that at Hopkins. It was really quite remarkable. We live in a city where less than 5% of the population is Latino, but during the early days of the pandemic, the number of patients that were Spanish speaking in our system with COVID-19 was really unprecedented. And likewise, it was the same in other partner hospitals in Maryland. And as we met these patients and talked to them, we really got to understand what was going on. And this was not a surprise for those of us who work in this space. We had actually worried about this before when the pandemic started, but I think as we saw it unfold, we saw that it was even worse than we thought. And so I would say that the sort of driving factor here is the marginalization of a group of people, particularly immigrants and particularly those who are undocumented, and poverty. So that combination is just really quite lethal. So in terms of occupations, as Damani mentioned, many low-income Latinos and particularly immigrant Latinos are working in those front-facing employments. Many of them are low paid and also quite informal. And we have to remember that immigrants, and particularly those without documentation, didn't get any of that aid that was available to others when the pandemic started. And so people who are already poor, who didn't have a lot of reserve in terms of savings, were not going to get unemployment benefits. They were not going to get the stimulus check. And And because of that, they had to continue working. And so that's really what we saw. We saw people who continued to go to work at the early days of the pandemic. Many of us, including us, we didn't really know what the protections were. And so patients were not getting the right protections at work. Sometimes because there wasn't enough PPE, and sometimes because it wasn't clear what needed to be done. And I can give you specific examples, but for many people that we saw, they don't have transportation. They get picked up sometimes in the corner to go do some construction work or whatever, and they get all put in a van and go to that place of work. And that shared transportation was a really great recipe for transmission. Linked to that and to poverty, and something that Damani also mentioned is housing conditions. And so when people are poor, and especially if they don't have any assistance, they share housing. And this is quite common among Latinos, that there's multi-generational housing. And sometimes even people live together who don't even know each other, but it's a way of saving rent. And I have to say that it was really, I have worked with this community for a long time, but I guess until now I hadn't had to ask people, where do you live? And I was shocked at how many people, for how many people the answer was, I live in a basement. Not in a basement alone, but I live in a basement with 10 other workers, and we all are sharing a space. And so you can imagine, again, that the transmission under those circumstances is quite heavy. The other piece, I think, and I think Damani also alluded to, is a lack of access to care. And it can be particularly extreme for some group of Latinas, and again, immigrants in particular, who are specifically excluded from Medicaid and the Affordable Care Act. So we are early on heard, recommendations from the CDC and others that people should stay home, call their doctors, and get directions from their doctors about where to get tested and what to do. But for a large majority, a large group of people and a large group of Latinos, that wasn't an option. They didn't have a doctor. They not only didn't have a doctor, they weren't used to navigating the health system, so they didn't even know where to call. Some of the hotlines that were set up here and in the country, and the initial communications were only in English, and so that was also hard for people to navigate. And finally, so again, you have a group of people who have been for years and maybe decades, and many of these people have lived in this country for a long time, but they never, because of these exclusions, they haven't interacted with the health system. They don't know how to do it. They're poor. They're afraid of medical bills. They've heard that if you go to the ED, you get thousands of dollars of bills. And so that makes it very hard for people to take action and say, okay, I'm going to go to the emergency room or seek care. And then the other thing is that, and I think it really added to the whole situation, was that there has been a lot of anti-immigrant and frankly, minority rhetoric in this country for the last few years. And for immigrant families in particular, the fear of being separated from a family and deportation often overrides other fears. And understandably, there's a lot of institutional mistrust. And so some people were just afraid to come out. A lot of people have survived by living in the shadows. And so coming out to get help felt risky in that way. Again, I do want to clarify that this does not mean that all, my comments right now are very specific to Latino immigrants, and particularly low-income Latinos. Not all, in fact, the majority of Latinos in this country are not immigrant. However, it is very common in Latino families to have immigrants within the families, to have mixed situations. And so, as Damani very well, nicely put it, whatever affects one group of people affects other group of people. And certainly when we have families, and I know many families where there's even disparities in access within the same family, within sibling families, within siblings, you can imagine if the impact that can have multi-generationally, not just to the immigrant themselves, but to everyone else. And I think, those are the ingredients that really made, and unfortunately, a perfect storm for this high prevalence of disease that we've seen among Latinos, as well as high mortality.
Thank you so much, Dr. Page, and thank you for all of your work. I do just want to take a moment to highlight, as a part of our MLK activities, Dr. Page is winning the Dr. Levi Watkins Ideals Award for all of the work that she's done on COVID-19 during this pandemic. So just a huge congratulations to her and her team for all the work that they've done on this issue.
I just want to say how humbled and honored I am about that, and really to say that this is not, it was a team effort, and this credit goes to the whole team, including many people on this call, and Sharita, who has been incredibly supportive of this work. So I am very thankful to leaders like her, because without her, we can't get this work done.
Thank you so much. So next, I'm very happy to introduce Ms. Deanna Behill. She is a research program coordinator at the Center for American Indian Health at the Johns Hopkins Bloomberg School of Public Health, and currently lives on the Navajo Nation. Ms. Behill, the Navajo Nation has suffered significant morbidity and mortality during the COVID-19 pandemic. Can you discuss the contributing factors for the Native American community with us?
Sure. Thank you, Dr. Irvin. Umbiak Gindi, na kawe Diana Vihil, na wito kawe ove goyo, na nambe winge ota. I just said my name is Diana Vihil. I'm from Nambe Pueblo, New Mexico. I am Tewa. However, I do live on the Navajo Nation, and that is where I work. So I started working here in February of last year, and then COVID hit. So 3 weeks later, we were on lockdown orders, and my role changed, and as many people did, and everything sort of shifted. So I've really been able to be exposed to the issues that are specific to the Navajo Nation, but also issues that Dr. Page and Dr. Piggott have mentioned that are common to all sort of marginalized groups or oppressed groups in this country and abroad. And so some of the things that are some of the contributing factors that are talked about when in regards to the Navajo Nation and other Native communities are things like an underfunded Indian health services, which gets an incredibly low amount of dollars per person, and lack of running water, rural sort of spread out stuff, so lack of resources, and not enough people to maybe do all of the contact tracing that's needed or the case management work that's needed so that people can stay home. And we've had examples where on the community there are individuals who work at some fast food restaurants and with many people, and they've tested positive for COVID-19, but they were unable to take leave because their work didn't pay them, and they had to feed their family and their extended family and bills to pay. And it was starting to get colder, and people have to pay for propane, which is very expensive. So there's all these factors that go into it, and there's a lot of unsheltered relatives that live here on the nation, as well as many Native communities and what we call border towns, which are the towns that border reservations. And those are, due to systems that have been mentioned before, but we have these situations where now people are getting kicked out of their homes because they have COVID-19 and their family's afraid of getting it. And so where do they go? How are they able to get care? How are they able to take care of themselves and do all of the things that are recommended when someone does have COVID-19? So those are some of the issues that are specific to the Navajo Nation and Native communities. But some of my issues with the way that those factors are discussed in the mainstream media are that they either sound like a Native problem. So why haven't Natives done this? Why haven't the tribal governments done this? Or, we're so-called sovereign. Why haven't we done these things for our people? The other thing that this feeds into sometimes is this mythicization of Native people. And so a lot of people from the outside look at us as, these like helpless Indians that need saving. And so that's also harmful to how we're able to pull ourselves out of these situations now and in the long term. And another thing that's true, but is not the entire story, is that we are just entirely failed by the US government, right? So the Navajo Nation had to sue the president for CARES Act money, as an example. And all of these conversations sort of occur without examining the structures that got us here, which are capitalism, white supremacy, and the ongoing colonization of Black and Indigenous peoples. And these aren't issues that individual choice or more resources or more funding can fix alone. They are things that need to be abolished so that we can create something that works for all of us. As Dr. Piggott mentioned, we need something that includes everyone, not just the few, privilege or the few in power. And so when we see these side effects and they are highlighted, as both Dr. Page and Dr. Piggott mentioned, in the Black, Indigenous, and Latina communities during this pandemic, but they are things that we have experienced and fought against, for the last 500 years. This isn't new to us. This is new to maybe people who have been sheltered from these realities, but they're not new to us. And until we acknowledge these structures by name and we understand how they are upheld and actively work to dismantle them, we're going to continue to see these inequities and these disparities for this entire country and globally, as the US is a global empire. So it's my hope that with conversations like these, and thank you so much for hosting them, but with conversations like these, we bring more awareness to these issues, and we form groups who can better address these issues as a collective. And the more people that we have together, the more power we have over these systems that oppress us. Thank you.
Thank you so much, Ms. Vigil. I think what we can see is really the unifying themes from our kind of first three speakers that have highlighted why we see these health disparities in COVID-19. So now we're going to transition to talk a little bit about the science of the COVID-19 vaccines. And we're going to have Ms. Brittany Fehu, a nurse practitioner and research associate in the Department of International Health and the Center for Immunization Research at the Johns Hopkins Bloomberg Public School of Health, come and speak to us about that now. So we actually have several questions for you today, Ms. Fehu. Can you first tell us what is an emergency use authorization, or EUA, and really why it's being used for emerging COVID-19 treatments and vaccines?
Yeah, so first off, thank you, Dr. Irvin and Dr. Golden, for allowing me to participate in today's conversation. And I'm wearing a mask today because I'm actually on our unit right now doing vaccine trials, so excuse the mask. But to go into your question about emergency use authorization, so basically these allow the FDA to provide us kind of timely access to drugs, diagnostics, vaccines, and other treatments during a pandemic or any other type of emergency situation. And the main kind of focus around these are that they allow us to quickly authorize the use of these in a fashion with limited efficacy and safety data. Typically they're used, typically they allow us to get this approval within weeks, sometimes a month or so, whereas FDA approval can typically take up to a year. So in the case of this, emerging pandemic, we needed vaccines to be used within the community right away. So using the EUA route throughout the FDA allowed us to have these vaccines available to the public immediately.
Thank you so much for explaining that to us. As a follow-up, can you explain Operation Warp Speed to us? Many people, including the community group I work with, have concerns that the rapid vaccine development was driven by politics or that safety was in some way compromised for speed. So can you tell us why was this vaccine developed so quickly, and is that unusual?
So Operation Warp Speed was the US government initiative to help develop COVID-19 vaccines. And the goal is, of course, to develop these in an expedited fashion because of the need, the urgency, and the rising cases of COVID in the US and the world. And so this federally funded program was an effort between the Department of Health and Human Services, the Department of Defense, and also the private sector. And the goal was pretty much to kind of remove any type of financial, technical, and logistical barrier to help get us a vaccine as soon as possible. Now, in the process, though, safety was not compromised. These vaccines still went through the normal channels of going through the phase 1, phase 2, and then phase 3 trials, where we were evaluating for safety and efficacy. I guess the main thing that was different, and is why we got the vaccines expedited, is because literally everyone in the country and around the world pulled resources together to work on these vaccines. To put it into a little bit of perspective, at the Center for Immunization Research, we typically work on vaccines involving flu. We also do Shigella, any type of dengue type viruses, other flaviviruses. But when coronavirus hit in the pandemic, our focus was on COVID-19. So since August is when we started our Pfizer trial here, that's all we've been doing is COVID. And that's likewise among research centers around the US and the world. Another thing too, that kind of is a component of Operation Warp Speed is something that was formed called the Coronavirus Prevention Network. And that network was used here in the US and internationally. And basically it was allowing different sites to have kind of a coordinated effort in enrolling people for vaccine trials and therapeutics. So the Center for Immunization Research is actually a part of this network. And as a result, there was funding through the NIH, specifically the National Institutes of Allergy and Infectious Disease, to help support enrolling participants in these trials, and also funding any extra equipment and supplies that were needed. One in particular, we actually started mobile health clinics too, to allow us to enroll people out in the communities as well. So all of those aspects allowed us to kind of expedite the process of vaccine development for coronaviruses, but still ensuring that safety was of the utmost importance.
Thank you so much. It's really been such a huge mobilization effort to get these COVID-19 vaccines out into the community. Thank you for explaining that to us. So, we talked earlier about, the 2 vaccines that are approved now are the Pfizer and Moderna, which are mRNA vaccines. Can you describe how the mRNA vaccine technology really works in layman's terms to us?
Yeah, so the Pfizer and Moderna vaccines are both mRNA, and mRNA is as what we call a vaccine type platform. There's different types of vaccine platforms that we use. In the past, you've probably heard of things called, live and attenuated vaccines. mRNA is novel in a sense that it's something that has never been approved or licensed before. And the vaccines itself work by, instead of using the virus, we use just a little bit of the genetic material from the coronavirus. And that genetic material in this case is RNA. And that RNA is encapsulated in a lipid kind of coating in order to go into a human cell. When this happens, you're able to make copies of the virus protein. In this case, it's this spike protein, which is the one that's been used, or S protein, in making all of the coronavirus vaccines. That it then triggers the body to make an immune response, making antibodies to the spike protein. And so basically, that allows us to have a vaccine that isn't replicating in the body. And the reason why they were being able to make it so fast is because we're not actually having to use the entire virus, just the genetic code material for it. And both Pfizer and Moderna, these are, like I said, the first time these have ever been actually licensed. Or I should say authorized.
Yes, thank you so much for explaining that to us. So maybe we'll just move on to a couple other things about the trials, because I think people have questions about this too.
Of course.
During the trials were, Blacks, Latinx populations, and other minority populations included in these trials. Can you speak to that for us?
So that was definitely a priority, especially with an Operation Warp Speed. They wanted to make sure that these trials included individuals that represented the demographics within the United States. For Pfizer in particular, looking at some of the demographic data, they saw that 82% of the trial participants were white Caucasian. 10% were African American, and roughly about 26% were Hispanic Latinx. They were hoping to get a little bit more participation within the African American community and Hispanic community. They were, lots of efforts have been made in order to get out into the community and talk about it, but a lot of it had to do with, as we mentioned before in our conversations, distrust and mistrust in the medical community, because of other things that have happened within minority populations. So I think a lot of that lowered enrollment within these groups. Moderna, their kind of distribution looked a little better. They had about 63% white Caucasian, 10% African American, and 20% Latinx or Hispanic. I can say right now we're enrolling for AstraZeneca, and we have seen quite a bit of an uptake in minority enrollment within AstraZeneca, at least at our site I can speak for. I think a lot of that has to do with just the continued information and media presence about enrolling in trials and the need for our minorities to enroll in trials. One thing that I often do when I'm enrolling participants in these trials is I ask them, if it's whether they're minority or not, why did you decide to enroll? And often my minority patients said, because I realize that this is, impacting us and I want to help. And they are also, word of mouth has been a really big effort too in getting minorities and to enroll in these trials too, because they've told family members and so forth. And we've definitely seen, like I said, an increase here in the minority enrollment. And as of now, AstraZeneca is only enrolling people of diverse backgrounds or people over the age of 65, because they really do want to increase that demographic within trials.
Thank you so much. And I think you bring up a point too, that vaccine trials are ongoing. While we have two under EUA right now, there will be other vaccine trials that will continue to go on. So now I want to kind of switch and talk about how we get the vaccine to people. How do we focus on making sure the vaccine is really available to those highest at risk?
Yeah, those high at risk we know are people who are from diverse backgrounds, people of color. And we also know it's people with chronic medical conditions and those over the age of 65. And I think it's really going to be a coordinated effort between, federal, state, and local officials. I guess our focus now too is just the process of vaccine distribution in general. As you know, right now, it's been extremely difficult to get vaccine out. We were hoping that, by the end of December, we would have had all 20 million doses that we originally had out to the public. And we're really lagging behind other countries in doing that. I think as far as getting to the most high-risk groups, it's going to take a lot of education too, because vaccine acceptance is definitely an issue within this group. And a lot of that has to do with the mistrust in the past. So addressing those concerns, making sure we have resources available and education surrounding vaccines, especially the COVID vaccines. I think to get out to community, especially in areas, as Diana has said, on reservations, we really have to think about the cold chain process too. Because Pfizer, at least, it has to be stored at -70, which creates a lot of different logistical challenges. The Moderna vaccine itself, that one I think is regular freezer temperature, which makes it a little bit easier, but still getting out to certain communities, we have to think about, how are we going to supply freezers and other transport, issues to get these out, individuals to vaccinate. So I think it's a planned stepped approach, but mobile health clinics are something that we're also thinking would probably a best option too, because we can actually take those clinics to those communities and vaccinate individuals. And I think as time tells, once we figure out, vaccine distribution and how to get it to, the priority groups, what we're dealing with now, I think it's going to be a process, but I definitely think it's feasible.
Thank you so much.
Mhm.
One of the things you mentioned was community education, and that's something that we've been working on at Hopkins, and Dr. Golden has been leading our kind of internal and external strategy as we work to educate everyone in the community about COVID-19 vaccines. Finally, I want to turn back to Ms. Vigil quickly to kind of follow up on the Navajo Nation. What has been your approach to COVID-19 vaccine education in the Navajo Nation? And what concerns have been raised that you are addressing within the community right now?
Thank you. Many of the concerns that have been raised are similar to concerns that others have raised, mistrust, those types of things. But some other things are genetic. So some people are concerned that because it is an mRNA vaccine, that it can cause genetic changes or alterations in the body, which is certainly not the case because of where mRNA works in the cells versus where our DNA lives. So those are some of the main things. There's some hesitancy about how it was made, how fast it was created, is it safe enough? Have we been studying this long enough? Are there potential long-term effects? Alternatively, there are some folks who are hesitant because they have underlying health conditions and they're not sure how they'll react to this, or maybe they're immunocompromised and don't want to add something else, onto their immune system. So there are several different factors, but how we've really been handling communication, it started in the beginning. So we have a Pfizer, the Navajo Nation has a couple sites where we are doing the Pfizer COVID-19 clinical trial, vaccine trial. And so it really started then, having community meetings and just trying to explain how the vaccine was created, how it works, the research process, how we got community consent, how the study got approved, the informed consent process. So it really started then, but has shifted more towards working with the Navajo Nation Department of Health to try to boost their materials and share what we have. We have a translation group. So their goal is to turn a lot of these materials into or translate them into the Dene language. And so it can reach more people. Radio is huge out here. So we try to do some radio PSAs in both Navajo and English, and just talk to people one-on-one. A lot of people call our office with questions. So we address it in that ways. There are several community groups like the Dene Hitachi Association, which is a group of traditional practitioners. And so we try to meet with them regularly to just answer questions, provide the latest information. So those are the approaches that we've taken, really just trying to reach out to people and get the word out. Unfortunately, we're still not able to reach a lot of folks. And even after we do, there's still some hesitancy. But I think it's making a difference. And as more people see other people get vaccinated and see that they're doing fine, and maybe they had some symptoms, but it was just mild, I think that takes more of their fears away, and people are more willing to step up and get their vaccines.
Thank you so much. This panel was really amazing, and I've learned so much information just sitting here. I'm going to turn it back over to Dr. Sharita Golden now, and again, want to thank her for pulling this panel together to give us such great information.
Yes, and also thank you all. You all have all been amazing and really shared a lot of important information with all of us. So I want to go through some of the questions that have been coming in from the audience. And one of them, I'll actually answer the first one. I'm glad that this was raised and want to reassure the audience that we are addressing this. But this is from one of our employees said this morning. They found out something from a cafeteria worker in the building, that most of the cafeteria workers in the building across our campuses are contracted vendors and not Hopkins employees. Hopkins hasn't made any arrangements for their vaccination. And so just to clarify, and the question was, is it possible to convey this concern to the powers that be so the Hopkins cafeteria workers don't fall by the wayside in the overall vaccination effort? And so, so I've been co-chairing a COVID vaccine equity task force internally, specifically focused on our employees with Dr. Katie O'Connor, who's the operations chief in the command center. And in fact, those group of employees are a part of our plan. And so it's sort of listed under like dietary. And so, but because we have several groups of contracted employees in our health system, so we have security workers, some of our environmental services, some of our food services workers. And so what we've done is set up MyChart activation stations throughout the organization, and then also have alerted those managers to make sure that those employees get their MyChart accounts activated. And we actually have people that will help walk them through that process, so that they can then log into the vaccine request form to determine whether they want to get that or not. But we learned this morning that some of the contracted workers who are part of our food services had inadvertently been not included in that original group. So they now are, we are literally working on that as we speak. We just found that out this morning. So thank you for bringing that to our attention. And we've been really making sure, if you think of other groups that you hear about across our system who are really in harm's way because they are right on the front line, it's not just the doctors and nurses, but everyone on the front line, please reach out to our office so that we can make sure we address that. So the next question is, and maybe I'll direct this one to Brittany, is can you clarify a live and attenuated vaccine? What are examples of a live vaccine versus an attenuated, just to give some perspective?
Yeah, so our live vaccines are ones such as like the varicella vaccine, which is our chickenpox vaccine. We also have Shingrix, the newly licensed Shingrix is also a live vaccine. And those are ones that are actually using part of the live virus to help evoke an immune response to develop antibodies. Some of our inactivated and attenuated vaccines, the actual virus is kind of killed in a sense a little bit. So you're not actually going to have somewhat of a stronger immune response to it. They still will give you an immune response. So most of our flu vaccines, for instance, are all inactivated. There is the flu mist that is a live virus. So that's kind of the difference. With the particular mRNA vaccines, though, these are all inactivated. We're not using any type of live virus, at least the two that are currently have the EUA, the Pfizer and the Moderna.
All right, great. And there's another question related to the vaccine, is how the genetic code was created for the mRNA in the vaccine.
The genetic code, so they were using particularly for Pfizer and Moderna, the spike protein, so the S protein code, that RNA code for that. The coronavirus, there are other proteins that are also involved. There's an M protein that a lot of times that we're seeing in infection as well. But all of the vaccines right now have been created, especially the RNA vaccine, the mRNA vaccines using the S protein.
All right, great. And then this is another question. Is there any physiological reason why the vaccine would work differently in a Black or brown body than in the majority community?
That's a very good question. And so, we know that our genetic makeups are all different, and how we respond to not only vaccines, but also drugs and other therapeutics varies. What we don't have any evidence right now that there's any difference. Of course, we have very limited data with these trials that the vaccines act differently within people of different ethnic backgrounds. However, what we do know about most vaccines is that sometimes there's a difference regarding age. As we age, we experience something called immunosenescence. So our body doesn't have the same immune response to vaccines. It's a little bit decreased. That's one of the reasons why for a flu vaccine, for an example, there's a high dose flu vaccine for people 65 and older, and it gives them a little bit more of a dose because we notice giving them a regular dose of flu vaccine doesn't protect them as much. So we're wondering if, down the line for, COVID-19 vaccines, if that's something that is also going to be considered. People age 65 and older will need a stronger dose. We have seen in our trials so far that with 65 and older, they tend to have not as much of symptoms after getting vaccinated. So it's the younger individuals that have more symptoms. And again, we think it's just because of how the immune system works.
All right, great. And then there's another question about how that we specifically disseminate the information for trial participants, particularly in the African American community and others.
I'm sorry, can you repeat that?
So there was a question about how is information disseminated about the trials, so that that information could be available to help recruit African Americans as well as other groups.
Yeah, so the Coronavirus Prevention Network has done a great job of kind of promoting the need for participation among African Americans and other people of color within these trials. There's also been a lot of media press about the need for involvement. At our site too, word of mouth has been a big way too of getting people to enroll. We have through the Coronavirus Prevention Network, there's actually a way that people can go online and kind of give their information. And we've pulled directly from that list in order to recruit as well. So yeah, those are some of the ways.
All right, great. And the next it was just a comment of worrying about our housekeeping staff too. And so our housekeeping staff are part of the groups that we've been outreaching to as well. So then there's another question. If you don't work with patients, but you're HIV positive, do you still have to wait to get the shot? So in other words, like you may not be working directly with patients who might have COVID, but you've got a comorbidity or a risk or a disease. And I think right now the way the state has distributed its vaccines is for frontline healthcare workers. And so, right now within our health system, we've thought about the distribution and allocation of vaccines as those who are on the immediate front line. So in the COVID units and the emergency departments and non-COVID units where you may not know that someone has COVID, for example. And then again, like our other, maybe in addition to the physicians and the nurses, all of our respiratory therapists, social workers, environmental service workers, security, anyone who's really in harm's way just by virtue of coming here. And then also, who are the people that are essential to the clinical operations of our system? So keeping, everything going. So right now, at least in Maryland, the vaccine doses are being designated for healthcare workers. And I know the Maryland State Health Department, through looking at licensed providers, have started putting out information about how to get to that. And then like the patients will be the next group. So that's sort of where we are in the state because of the way the doses have been allocated. I don't know if anyone else has anything to add about that while there's another couple of questions to get to.
Rita, just to say there's also questions on the chat. There's two.
Yeah, I saw that there's questions on the chat. That's why. So I'm going to ask this question. I'm going to go over to the chat. So are there employees who've received the vaccine, or the employees who are receiving the vaccine participating in a trial for research? And I can answer that question from the employee standpoint. No, the reason that employees are having to sign a consent form is understanding that this is an emergency use authorization. So because anything that's under an emergency use authorization, you have the option to to take it or not. And so I will transparently indicate that my vaccine appointment is next Tuesday. And so when I went in, I got the alert from the MyChart yesterday, and I went in. I had to go in, review all of the information in the consent, and sign. So the reason that people are signing is because it's under an emergency use authorization, because we're in a public health emergency. We don't have all the long-term data that we might normally have. So that's the reason it's signing. But this is not a part of research. This is public health prevention and public health intervention. So I'm going to switch over to the chat. I know there were some questions. Hold on. And I think Dr. Damani Dr. Piggott may have answered part of this, but there was a question about whether or not lower levels of vitamin D in African Americans may predispose them to a worse outcome with COVID or a higher likelihood of infection. And so I don't know if maybe briefly, Dr. Piggott, if you were willing to summarize that and the study that you alluded to in the answer.
Sure. So definitely the range of vitamins that have come up, vitamin D, vitamin C, zinc, etc. Earlier on, for which we didn't have as a therapeutic option, for which we didn't have robust data to support. There has been some incipient data on the relationship of low vitamin D to COVID outcomes, with a suggestion that there might be some association there. There is an open label randomized control trial that was done. It was pretty small, which may have shown a little bit of signal, but that has to be examined in much larger trials. And right now, it's not a definitive therapeutic for treatment of COVID-19.
All right, great. And then this is an important question. I work in an area in which I can have conversations with African Americans once a week from all work roles. Their biggest statement is that they will not get the vaccine and do not want phone calls for more information. They believe the vaccine is not safe and are still reeling from the Tuskegee projects as well as Hopkins' history of research in this population. Do you have any suggestions on how to support these employees? So I'm interested in the panelists' response. I think one thing that's really important is to acknowledge, I understand why it is based on this prior experience that you feel this way. So in other words, not to gaslight or dismiss that, because those things did happen. And even when I think about the Tuskegee experiment, it ended when I was 4 years old. I mean, so we're talking about in a recent lifetime, but so I think you need to acknowledge that. I understand. And I think the thing that became helpful for me in thinking about this, though, were all the people I know who contracted COVID and have died. We have people on both sides of the family that have died. And so, sort of weighing the risks and benefits, the scale for me tipped toward getting the vaccine because I, have, educated myself to understand the process and the safety to feel comfortable. But I think you can't disregard the fact that people have those feelings. I'd be interested if any of the panelists have any other comment about that.
Yeah, I share Dr. Golden's feelings, definitely. I think for me, in my thinking about getting the vaccine myself, as well as in talking to family and friends about the vaccine, I think really there are three pieces. One is what is the impact? And we know that COVID-19 has been really, really bad and has had really, really bad effects. We've lost many people from COVID-19. So what is the potential benefit that the vaccine might have in terms of preventing death, preventing hospitalizations, preventing disability? The second piece is with healthy skepticism, being informed by data, and I think this is one of the things that we're all trying to do to some degree, is to make sure that folks are equipped with the information that actually is out there in an honest way as well, so that folks can make informed decisions for themselves as to whether this is right for them, whether it be right at this exact time or in the near future per se as well, I think is the second piece. And the third piece, just from the perspective of the person who's sharing, I think is it's not just the message, it definitely is the messenger, and thinking about who has the trust. My grandmother probably, who's in her 90s and who is at high risk, probably, we have a relationship dating back to, well, at least to my birth. And so I think our conversations, right, are going to be a little bit different than what you might see on TV or otherwise as well. And I think there are folks who've really devoted effort and time to, and it sounds like you may have as well, to building up these relationships in the community. And I think if one feels comfortable with the data and the impact and the risk-benefit perspective, I think leveraging those relationships also, I think, are key.
So thank you. So we are right at time. It's a very engaging dialogue, and Dr. Irvin has put in the chat, we're going to save the chat, so if there are any questions we didn't get to, we will send follow-up. And if you think of additional questions, she's also left an email where those can be sent. And, we really want to thank you for tuning in and engaging. And, I think as you're thinking about your decisions about the COVID-19 vaccine, I think you have to think about your why, and the balance. And I will just show that, this will be my why. These are my parents. They both turned 85 in 2020. And, every 2 weeks I go down to a system, and I became very concerned about what I might be taking. So I think we have to really begin to weigh the risks and benefits. I've just seen so many people in my community dying, and I had to educate myself and really, look at the checks and balances and those things. And so, you will see us working with our employees, helping to answer their questions and to hear their concerns, because I think listening is an important part of helping to activate people. So we want to thank you for tuning in. Thank you to all the wonderful panelists. You were all excellent in your perspectives. And just to remind you that later on today, we have a program that's focused on disability inclusion at 2 p.m. So please tune in for that as well. Thank you. I'm not sure if she stopped recording.